Good morning, dear colleagues. My first topic today will be the diagnostic workup of some common clinical scenarios. In breast imaging, it is challenging enough to be able to diagnose the underlying cause behind breast symptoms. Yet the biggest challenge is how to apply the best practice to do so. And to do so, we must be able to choose the most appropriate imaging modality for the patient, and we must be able to correlate what we see in this imaging modality with the clinical data. The breast imaging cycle usually starts with a patient who is symptomatic or asymptomatic. The patient is referred to a clinician. The clinician orders a specific imaging modality, and he refers the patient to the radiologist who might approve or disapprove this modality. The radiologist then writes the report and he gives it back to the patient, and the patient is referred back to his clinician. Usually this breast imaging cycle should go on smoothly, but it might become disrupted if the clinician orders for a wrong exam to the patient, and when radiologists sometimes recommend unnecessary added imaging. And when we only had mammography and ultrasound in hand, things were easy, where an asymptomatic patient is referred for regular screening mammography if she's more than 40 years, and if she's a high-risk individual, she might be referred for screening at an earlier age. Well, if she's less than 40 years, no screening is recommended. After doing the screening mammogram, she might need further ultrasound examination, and she might be referred for further intervention. For symptomatic patients, we usually look at the patient's age, whether she's pregnant or lactating, and if she's younger than 40 years, she starts with an ultrasound examination. More than 40 years, we usually start with a mammography examination, and we might recommend for either additional studies. And again, the patient might be referred for further intervention. But now having more and more imaging modalities in hand with the mammography, you will hear about the tomosynthesis, the contrast mammography, and the PET mammography. With the ultrasound, we have the Doppler, the elastography, and the automated breast ultrasound. And with MRI, we have the diffusion and the spectroscopy. I think we have to admit that the volume of breast imaging modalities have grown exponentially, and thus implementing some practice has become a real challenge. And so today we will learn together how we can incorporate these modern breast imaging modalities in the diagnostic workup of some common clinical scenarios. But before doing so, we should understand the basic principles behind these modalities. We all know that in mammography, the patients are imaged in the upright position. The breast is gently stabilized and compressed between the compression plate and the detector. And then we image the breast in two views. The first view is the craniocaudal view. And in a craniocaudal view, we can say whether lesions present in the breast are seen in the outer or the inner breast quadrant. The second view is the mediolateral oblique view, and in a mediolateral oblique view, which looks like this, we can say that whether the lesions seen in the breast are seen in the upper or the lower breast quadrants. But because we compress all the breast tissues over each other and then we image the breast, mammography has always been accused of having major technical limitations. It has always been accused of having a low sensitivity because the normal breast tissues might obscure an abnormality, and this is responsible for a large number of false negative results. It's always accused also of having a low specificity because the superimposed breast tissues might give the impression of a false abnormality, and this is responsible for a large number of false positive results. And this is one applied examples which show us the real limitations of mammography. In this heterogeneous dense breast parenchyma, we can see nothing, although clearly on the ultrasound examination, we can see multiple variable-sized hypoechoic lesions, which prove to be a multicentric carcinoma, and they can be hardly seen within the mammogram of the patient. The challenge with mammography interpretation even increases more whenever we have younger individuals, whenever we have a dense breast parenchyma, especially when this dense breast parenchyma is heterogeneous, whenever we have non-distorting and non-calcified carcinomas seen within the breast, and sometimes it's not because of the mammography, but because of the radiologist's bad perception and misinterpretation of the mammograms. And that's why we moved a step forward, and now we have in hand the 3D digital tomosynthesis. The principle of 3D digital tomosynthesis is more or less like a mammogram, where the breast is placed here between the compression plate and the digital detector. But what's different from a mammogram is that the X-ray tube moves in an arc across the breast, taking a series of low-dose images that are acquired at different angles. The total dose of these images is similar to a single view or slightly higher than a single view mammogram. And because we image the breast from different angles, we can then have a reconstructed 3D image. But when we view this reconstructed 3D image, we can view it every 1 millimeter, exactly like what we do in the CT examination. And by this, we can remove the problem of overlapping tissues and the superimposed tissues. This is one example which shows you how 3D digital tomosynthesis works. If we have multiple lesions on the same level on a mammogram, for example, here we can imagine that this is calcification, this is an area showing parenchymal distortion, and this is a speculated mass lesion. If we just compress the breast and image it like what we do in a mammogram, this is how they will, the 3 lesions will appear. And now we are unable to characterize any of them. Well, if we move through the tomosynthesis slices, a slice will pass through the calcification, another slice might pass through the distortion, and the third slice might pass through the speculated mass lesion. And by this, we can see each lesion individually, and we can be able to characterize each of these lesions. This is an example where these are the tomosynthesis slices. We view all the slices first, and then we select the slices in which the lesion appears more apparent. And these were the 3 slices. And now we can say that we have a hyperdense speculated mass lesion within the right breast. If we look at 3D digital tomosynthesis, we might think that it has solved all the problems of breast imaging. But actually, to be true with you, that the best results in breast imaging are from modalities which can combine an enhanced morphology assessment, and in the same time, they can give us some functional information about the tumor cells. And this functional information might be obtained through the injection of contrast media, like what we do in contrast mammography and in MRI, and it might be obtained by assessing the metabolic activity of the tumor cells, like what we do in PET mammography. And if we look at tomosynthesis, yes, it allows for an enhanced morphology assessment, but it gives us no additional functional information. And that's why we moved another step, and now we have modalities which depend on the process of angiogenesis through the injection of contrast media. As the tumor cells enlarge and divide, they secrete a pro-angiogenic factor. And this pro-angiogenic factor stimulates the proliferation of new blood vessels and new capillaries to supply the tumor cells with oxygen and nutrients. But actually, these tumor cells and capillaries are not well formed. They allow leakage of the contrast media within the surrounding parenchyma and within the tumor itself. And that is why we can see malignant lesions evidently enhancing within the breast. And this is the main principle that we use in the MRI and the contrast mammography. In both contrast mammography and MRI, we inject contrast medium in order to highlight areas of concern within the breast. But in MRI, we take a series of pre-contrast images and post-contrast images. We then subtract both from each other to get a subtracted image in which everything is canceled from the breast except the enhancing lesion, which is outstanding in the MRI images. In contrast mammography, it is the same, but what's different is that we do not take a pre and the post-contrast image. Both images in the contrast mammography are taken after injection of contrast. We take a series of low energy image, and this low energy image is exactly like the normal mammogram. And this is one advantage of contrast mammography, is that we can still see the microcalcifications within the mammograph. And when we take another series of image called the high energy image, and these are not diagnostic images, but they are very sensitive to the iodine content of the breast. We then subtract both images from each other to get a recombined image. And the recombined image, everything is canceled in the recombined image except for the tumor which has uptaken the contrast medium. This is an example of a case where we did 3D digital tomosynthesis, yet we still needed to do a contrast mammography. This 35-year-old female, she had a palpable left breast mass lesion. And corresponding to this palpable mass lesion, we can see that we have a speculated mass lesion. It is evidently seen maybe more on the CC view than it was on the on the mediolateral oblique view. And this was her tomosynthesis image, and you can see the difference between the mammogram and the tomosynthesis. The lesion is better seen with a speculated outline, and we can easily say that this is a malignant mass lesion. Unfortunately, during performing an ultrasound examination, we saw this tiny lesion in the right retroareolar lesion. Going back to her mammogram and the tomosynthesis, we were not sure where this lesion was. And so we had to perform contrast mammography. And on contrast mammography, we can now see that this tiny lesion is evidently seen better on the contrast mammography than it was on the mammography and on the tomosynthesis. And it was not only this, but if we see the lesion on the left side, it was not a single lesion. And we can see that there are multiple lesions seen within the left breast with a much wider extension than what we saw on the mammogram and the tomosynthesis. And this was a multifocal malignant mass lesion in the left breast. The third modality that we are going to see examples today is the automated breast ultrasound. Automated breast ultrasound, which is known as ABUS, is a new technology in the field of ultrasound that has developed to overcome the issue of operator dependence of conventional ultrasound scanning by standardization of the images acquired. ABUS is a 3D volume imaging technique offering proper positioning and documentation of the breast. During an ABUS examination, the patient lies supine, the same position as she does in the 2D ultrasound. But what's different, it's not a probe which images the breast. It uses high-frequency transducers housed in a paddle that is held by the technologist, seeing the breast, the whole volume of the breast. The paddle is used to lightly compress the breast against the chest wall. A standard ABUS protocol entails the scanning of each breast individually in 3 planes. We take an AP view, a lateral, and a medial view, and sometimes we need additional view, for example, to view the axilla. And if we have a large breast, we might need additional views to cover the whole volume of the breast. ABUS allows volumetric acquisition of the breast that can be stored and post-processed, and it leads to better image reproducibility and thus making it easier to compare with previous and subsequent follow-up studies of the same patient. The ABUS images are viewed on specific workstations in both a 3D and a 2D model. And now we go back to our clinical scenarios. And the first scenario that we will discuss is the screening. And I usually tell them that in screening, we follow the traffic lights, where the female population is classified into an average risk individuals with no specific risk for developing breast cancer. And this group usually includes most of the female population. The second group is the moderate risk individuals who have a risk which is 15 to 20% higher than the general population. And this group includes patients with past history of breast cancer, patients who have removed lesions from the breast, which turned out to be proliferative precancer, precancerous lesions, and those patients which we commonly see with a heterogeneous dense breast parenchyma. The third group is the high-risk individuals who have a risk which is 20 to 25% higher than the general population, and these include patients with have a BRCA gene mutation, patients who have received a direct irradiation to the chest while they were young, and patients who have specific syndromes which combine both lesions in the endometrium, the ovary, and the GIT with breast cancer. For the average and the moderate risk individual, screening mammography is recommended after the age of 40 years, and the screening mammogram might be complemented with an ultrasound examination. For the high-risk individuals and some selected moderate risk individuals, mammography and ultrasound again are indicated, but we might recommend for an additional MRI examination together with screening. And for high-risk individuals, we usually start screening at a younger age of 35 years. If we look at contrast mammography, we will find that it has a potential to be used as a primary screening modality for this group of patients. Because why do a mammogram and then prefer the patient to perform an MRI examination when we can get the same results from one examination? But up till now, due to insufficient data, the contrast mammography is usually used on the diagnostic workup of the recalled patients from the screening programs, and it might be sometimes recommended for the follow-up of some patients, and we will see some applied examples. If we have ABUS or the tomosynthesis in our departments, they can be used for screening the three groups, and we will also see how we can use artificial intelligence to help us in screening programs. This is an asymptomatic woman coming for her annual screening mammogram. There were subtle microcalcifications that were hardly seen in the right breast, mainly on the magnified image, as you see here, but they were very difficult to be characterized. This was her tomosynthesis examination, and on tomosynthesis, we can see that the microcalcifications became more evident, and now we can say that we have suspicious groups of microcalcifications within the right breast. She was referred for a 2D ultrasound examination, and this was her automated breast ultrasound examination, the ABUS, which confirmed that the presence of a hypoechoic irregular speculated mass lesion that was biopsied and revealed an invasive duct carcinoma. This is another asymptomatic patient. She had this nodular lesion in the right lower inner quadrant, and the lesion could not be characterized whether this is benign or malignant. While looking on the tomosynthesis image, if we look at the lesion, now we can say, yes, it has microcalcific spot, but what's more important is that the outline of this lesion was speculated and it was not circumscribed as it appeared in the 2D mammogram. This was the 2D ultrasound, and this was the automated breast ultrasound, and they both showed an irregular mass. The relation to the nipple is excellently seen within the ABUS study, and a biopsy was taken, and again, this was an invasive duct carcinoma grade 2. This is another case. She had a subtle left breast focal asymmetry, which was difficult to characterize based on the mammography alone. We did tomosynthesis on recall, and this was how it appeared on the tomosynthesis, and this is how the lesion appeared on the ABUS, and the ABUS actually confirmed the benign nature of this lesion, which was a small fibroadenoma. This is another case. She had a very subtle lesion seen in the left breast, but it was again difficult to characterize on the mammography. This is how it appeared on the tomosynthesis with a speculated outline. And this is how it appeared on the ABUS and the 2D ultrasound, and it had a desmoplastic reaction with a finely speculated outline, and it was an invasive duct carcinoma. And now we come to the use of contrast mammography in screening. As we have just said, that contrast-enhanced mammography has the potential to be used in screening high-risk individuals. Because why perform mammography and MRI when we can use contrast mammography alone? But as I told you that up till now, we use it on recall and in the follow-up of some patients. This is a good example of a high-risk patient with a very strong family history of breast cancer, and this is how usually the breasts of high-risk individuals appear, where we can pinpoint multiple areas of concern within both breasts. This was her contrast mammogram, and as you see, all the parenchyma was canceled apart from these two tiny lesions seen in the left breast, and this was a multifocal invasive duct carcinoma. This is a screening mammogram, again, of an asymptomatic patient. She had this lesion within the inframammary fold, and lesions within the inframammary fold are usually hardly visualized in patients, hardly detected in patients because they are considered to be in a hidden area. An ultrasound examination was performed and it revealed a hypoechoic vascular lesion, and her axillary lymph nodes were also pathological with focal cortical thickening. This was her contrast mammogram, and on contrast mammogram, it showed the two lesions excellently, but they were already seen on the mammogram. But what contrast mammography added is the presence of this non-mass enhancement, which was an associated DCIS with an invasive duct carcinoma, and this was only seen on contrast mammography and not on the mammogram and not on the ultrasound as well. This is another asymptomatic patient. She came for her annual screening. She had this focal asymmetry in the left breast. A complementary ultrasound was performed on recall, and these were her axillary lymph nodes with a totally infiltrated hilum, and they were pathological. This was the contrast mammogram of the same patient, and it revealed a left lower inner quadrant spiculated enhancing mass lesion, which was an invasive duct carcinoma, which was metastatic to the axillary lymph nodes. This was a case, she had a heterogeneous dense breast parenchyma, and she was recalled because of this heterogeneous dense breast parenchyma. On recall, when we performed, she was assigned a BI-RADS 0, and I told you she was recalled. And on recall, we performed an ultrasound examination which showed multiple underlying hypoechoic malignant lesions within the right breast. Going back to her mammogram, we can only see one of these lesions here, and that's why we had to perform a contrast mammogram. This was her contrast mammogram, which revealed multiple focal areas showing focal non-mass enhancement, and surgical biopsy came with a multicentric invasive duct carcinoma of the right breast. This is another screening mammogram. The patient was classified as a moderate risk because of this heterogeneous dense breast parenchyma. On recall, she performed tomosynthesis, and again, tomosynthesis was non-informative. On her ultrasound examination, we saw the spiculated outline mass lesion in the right breast. So we had to perform contrast mammography, which could clearly see the carcinoma in the upper outer quadrant of the right breast. Even if you see it on contrast mammography and we go back to the 2D mammogram, it is very difficult to pinpoint where the lesion is, although it is evidently seen on contrast mammography. This was a screening of a mammogram of a participant that was recalled because of a right upper outer quadrant asymmetry. This is her 2016 examination. She had this asymmetry in the upper outer quadrant. Upon recall, this area showed very subtle contrast uptake, focal non-mass enhancement, and biopsy revealed no malignancy. It was simply focal adenotic tissue. In 2017, she was told, when you come for your next year follow-up, you should perform a contrast mammography directly and to diagnose if there is any developing asymmetry underlying what we saw. This was her contrast mammogram in 2017, and it looked the same as it was in 2016. And these were the recombined images, which all showed the same pattern of contrast uptake like in 2016. And now we know that this is a normal variation in this patient, that she had focal adenotic tissue in the upper outer quadrant. As I told you, now we use artificial intelligence to help us in the screening program. In the past few years, we have witnessed tremendous scientific advances in artificial intelligence, mainly aiming to provide greater precision in screening tasks. Up till now, AI is used as a second pair of eyes to radiologists in screening purposes. But adding quantitative assessment tools to deep learning models definitely will increase its potential use in the diagnostic setting, and we have practiced this in our routine everyday work. This is a screening mammogram of a 58-year-old female. She had a subtle asymmetry in the left upper outer quadrant. This was her tomosynthesis, which showed an underlying speculated mass lesion, and this was the AI, which marked the area with a high abnormality score. You might ask me, what is the use of artificial intelligence if I can see the lesion evidently on tomosynthesis? But I tell you that why do additional exposure to the patient where you can get the same result without any additional exposure to the patient, because the artificial intelligence pinpointed the same area that the 3D tomosynthesis highlighted. And this was an invasive duct carcinoma grade 2. This is another screening mammogram of a 57-year-old female. She had an evident lesion in the lower inner quadrant of the right breast, and we were not sure whether this was another lesion or no in the right breast. Even on the tomosynthesis images, we were again not sure whether there was a lesion present or no in the upper outer quadrant of the right breast. When we applied the artificial intelligence, both the lower and the upper lesions were marked with the artificial intelligence, and a biopsy was taken, and it was a multicentric invasive duct carcinoma grade 2. Looking at the contrast mammogram of the same patient, unfortunately, the upper outer quadrant did not only show one lesion, but there were 3 adjacent lesions in the upper outer quadrant. This is the speculated mass lesion. These are the upper outer quadrant speculated lesions, and this was her axillary lymph nodes on ultrasound, which appeared pathologically. This is a screening mammogram of a 41-year-old female, and it was assigned a BI-RADS1 by one of the colleagues. But when we referred to the artificial intelligence image, it pinpointed an area which showed a low abnormality index of 36% suspicion, but we had to go back to the mammogram to verify that there was no underlying lesions to this area. Unfortunately, going back to her mammogram, we found that there was a very subtle microcalcification underlying the area marked by the artificial intelligence. A stereotactic biopsy was performed, and for these subtle lesions, when you take a biopsy, you should image the biopsy course to make sure that they include the microcalcifications that you have seen on the mammogram. A biopsy was taken and the excision was performed, and it revealed an intermediate grade DCIS. This again is a screening mammogram of a 48-year-old female. She was assigned a BI-RADS1 in 2021. She came for her follow-up, and again, she was assigned a BI-RADS1. But on viewing, applying the artificial intelligence, it marked an area with an abnormality score of 60, so 68%. And that's why we had to go back to her mammogram. And going back, we saw this very tiny nodule seen in the left upper outer quadrant. When we magnified the image, there were very subtle, faint microcalcification associating this nodule. This was her contrast mammogram, and again, there was very subtle enhancement of this nodule, and this was the complementary ultrasound, which showed an underlying indeterminate hyperechoic lesion. Biopsy was taken, and this was an invasive tubular carcinoma. Now we move to the second station, which is the breast pain, or what we call a mastalgia. Mastalgia is a common symptom experienced by up to 80% of women at some point in their lives. Mastalgia might be non-cyclic or cyclic. It might be focal, involving less than 25% of the breast, or diffuse. And for the non-cyclic focal mastalgia, further imaging is appropriate to exclude underlying serious pathology. While for the cyclic diffuse mastalgia, further imaging other than regular screening is inappropriate. And if imaging is performed for these cases, it is mainly aiming to relieve patient anxiety and direct the referring physician. Mammography is often used to evaluate breast pain, and in most cases, no imaging correlate is found to explain the cause of this breast pain. And when clinicians insist on imaging evaluation of breast pain in the presence of negative clinical examination, this increases unnecessary additional imaging studies. And this is an example of unnecessary image. She was a 42-year-old female with cyclic mastalgia. On examination, nothing was palpable. The mastalgia was more on the left side. There was a subtle left upper outer quadrant asymmetry. This was her contrast mammogram. It was requested by her clinician, and there was no underlying enhancement. And no enhancement on a contrast mammography usually means that there is an underlying benign pathology. And this was simply a case of focal adenosis, and she was followed up. This is another case. She had also cyclic mastalgia, which again was more on the left side. There was a subtle asymmetry on her mammogram, and on ultrasound, underlying focal fibroglandular tissue condensation was seen. This was her axillary lymph nodes, which looked nonspecific, and we diagnosed the case as a focal adenosis for follow-up. When she went back to her clinician, he insisted to perform a contrast mammogram, and because focal adenosis is condensed fibroglandular tissue, sometimes it shows subtle enhancement on contrast mammography. And this was the case. She had subtle enhancement. And when the clinician saw this, he insisted on performing a biopsy, and the biopsy came back again with focal adenotic tissue. Sometimes patients with mastalgia, they should be imaged. This was a 28-year-old female with fibrocystic mammary changes and cyclic mastalgia. Then she suddenly developed right focal mastalgia on top that was neglected for 6 months. On her ultrasound examination, yes, she had fibrocystic mammary changes, but in between the cysts, there were irregular solid mass lesions. So we directly referred the patient for a contrast mammogram. And as you see on her mammogram, nothing was evident other than edema of the right breast. But on the contrast mammography, we had bilateral enhancing mass lesions, which was locally advanced on the right side. The third clinical scenario is the palpable mass lesions. A palpable breast mass is one of the most frequently encountered clinical complaints, and it is one of the commonest presenting features of breast carcinoma. In general, cancers presenting as palpable lumps tend to be more aggressive than screen-detected cancers, and they usually carry a much worse prognosis. When we have a palpable breast mass lesion, we look at the patient's age, if she's above 40 years or below 40 years, pregnant or lactating. Above 40 years, we start with a mammogram, which might be complemented with ultrasound, MRI, or biopsy. Less than 40 years, we usually start with an ultrasound, which might be complemented with mammography, MRI, and biopsy. But usually, no additional imaging is needed other than sonomammography. Then when our modern imaging technologies are indicated whenever we have a palpable breast mass lesion. They are indicated to identify lesions not seen on mammography, to confirm the benign or the malignant nature of these lesions. Whenever we have a dense breast parenchyma, and we can now understand that the dense breast parenchyma is the main disadvantage of mammography, to identify lesion multiplicity or to know the actual size and extension of lesions. I will give you examples of how we use 3D tomosynthesis. For example, this patient, she had a palpable mass. She had an indeterminate asymmetry seen on the mammogram corresponding to this left breast palpable mass. See the difference of what we see on a mammogram and on the 3D tomosynthesis. On the tomosynthesis, we can now say that we have a speculated mass lesion and that this lesion is malignant. This was the automated breast ultrasound of the same patient, and there was an underlying area of parenchymal distortion, which was hardly seen on the 2D ultrasound. This is another case. She had a lesion here in the left breast, but while on the tomosynthesis, the lesion became more evident that it is a speculated mass lesion, but it was not only one lesion, there was another lesion here, which was seen in the inner quadrant, and now we can say that we have a multicentric carcinoma of the left breast. This was a patient, she had bilateral lumpy breast, which was, she had a markedly heterogeneous dense breast parenchyma where we can pinpoint multiple areas of concern. The true area of concern is evidently seen on the contrast mammography, where we see this heterogeneously enhancing speculated mass lesion seen on the mammography. A biopsy was taken, and this was an invasive lobular carcinoma. This was a patient, she had bilateral mass lesions, and this was her contrast mammogram. We cannot say based on the mammogram which lesion is benign and which lesion is malignant. But if we look at the contrast mammogram on the lesion on the right side, it showed heterogeneous. It was, yes, circumscribed and rounded, but it showed heterogeneous contrast uptake. It was not only one lesion, there was another smaller lesion just adjacent to it, and there was anterior intraductal extension extending towards the nipple and reaching to the nipple. A biopsy was taken, and this was a triple negative breast cancer. While looking on the left breast mass lesion, it did not show any contrast uptake, and as we have just said, that a non-enhancing lesion on contrast mammography is usually benign, and this was a fibroadenoma. This is another case with an evident suspicious lesion in the right upper outer quadrant. And you might tell me, why should we perform a contrast mammography or any additional imaging for this patient? The main indication of additional imaging in this patient is to see the actual extension of the lesion, because the size of the lesion is very important for the surgeon and for the oncologist as well. This is her contrast mammogram, and as you see, we can see anterior extension of the lesion, and the lesion is much larger than what we saw on the 2D mammogram. This is another 40-year-old female. She had a nodular breast texture. This was her mammogram. She had bilateral multiple breast masses. This was the contrast mammography. All the lesions on the right side did not show any contrast uptake, and again, non-enhancement equals benign lesions, while all the lesions on the left side showed contrast uptake, and this was a multicentric invasive duct carcinoma. This is another 30-year-old lactating female. She had a palpable mass lesion. Because she was 30 years, we usually start with an ultrasound examination. She had this irregular shaped mass lesions with increased vascularity. This was her mammogram showing a focal asymmetry in the left breast. And this was her contrast mammogram, which showed an underlying homogeneously enhancing lesion. A biopsy was taken, and this lesion was a triple negative breast cancer. And usually in these type of triple negative breast cancer, they respond well to chemotherapy, and the chemotherapy is usually given before the operation, which we call the neoadjuvant chemotherapy, and not after the operation. And we have to follow up the patient whether she is a responder or no. And for this reason, the contrast mammography is very important. We do a baseline contrast mammogram, and after she finishes or completes the therapy, we do another contrast mammogram after completion of the neoadjuvant therapy. And as we see, the lesion has totally disappeared, and this is what we call a complete radiological response. This is another patient with a palpable left breast mass lesion, which was seen here in the upper outer quadrant. On ultrasound, there were multiple underlying lesions. It was not a single lesion. This was the contrast mammography, which showed a much wider extension of the lesion. And as I told you, the true extension is very important for both surgeons and oncologists. This is an example how we use MRI. She's a 29-year-old female presenting with a left breast lump. Her mammogram showed an irregular left breast mass lesion. This is the mass lesion. It appeared to be as if speculated. We plotted the time signal intensity curve, and it showed a delayed washout, which is a borderline. We will never be sure based on the kinematics whether this lesion is benign or malignant. This was the diffusion weighted image, and when the lesion appears white in the ADC map, then this is non-restricted diffusion, a sign of benign. And when we measure the ADC value, it was a high ADC value, again going with a benign pathology. The spectroscopy, there was no Colleen peak. The Colleen peak was very low, and a biopsy was taken from this lesion, and it was simply a fibroadenoma. And now we move to the next step, and this is the nipple discharge. Again, the nipple discharge is a common clinical complaint. At least 80% of women will experience an attack of nipple discharge during their reproductive years. The commonest cause of nipple discharge include intraductal papillomas, which is the commonest, ductictasia, malignant lesions like DCIS, and the main aim of imaging is to exclude underlying malignancy. Nipple discharge, as I told you, is a common clinical complaint. It might be physiologic or pathologic. Physiologic nipple discharge is usually bilateral, multi-orificial. It occurs on squeezing the breast. It is either milky, green, or yellow, and it may accompany ductictasia, mammary adenosis, or some inflammatory breast lesions. Pathologic nipple discharge, on the other hand, is usually unilateral, uniorificial. It occurs spontaneously, it is usually bloody, and it might accompany intraductal papillomas, periductal mastitis, and some malignant breast lesions. And so the first step in investigating nipple discharge is to examine the discharge and decide whether it is physiologic or pathologic. For physiologic nipple discharge, no specific imaging is needed other than regular screening if applicable. While for pathological nipple discharge, sonomammography is indicated, and only if negative should we recommend for MRI, contrast mammography, or further cytology. This is a 30-year-old female with history of ductal excision. Now she is complaining of bleeding per nipple from the same side on the left side. Looking at her mammogram, she had segmental microcalcifications, which were also apparent on the ultrasound examination. A contrast mammogram was performed in this case, although by biopsy it turned out to be a DCIS, but again, contrast mammography is indicated to tell the surgeon the true extension of the lesion. And she underwent a conservative surgery of the left breast. This is another patient. She had uniorificial bleeding per left nipple. She had left breast multiple linearly arranged and nodular lesions. And this was her contrast mammogram, which showed the same findings. Nothing was added to the mammogram. The same findings were seen. We can never decide whether these lesions are intraductal or not intraductal, whether they are benign or malignant based on what we see on the contrast mammography. While with a simple look on the ultrasound examination, we can see that these lesions are present within a dilated duct. They are intraductal papillary lesions, which are evidently seen. And actually, ultrasound is the best modality in assessing nipple discharge because it can tell us whether we have simple ductictasia, ductictasia with retained secretions, ductictasia with retained secretions with additional periductal inflammatory reaction. And it can also diagnose small intraductal papillomas with their characteristic central vascular pedicles. And it can tell us that if whenever we have an intraductal malignant lesion with increased vascularity and calcifications evidently seen on the ultrasound. Using ultrasound, we can also differentiate between inspissated intraductal secretions, which are separate from the duct wall and show no vascularity, from intraductal papillomas with the characteristic central vascular pedicle. But to be able to do so, we must use a proper ultrasound technique, because if we directly place the probe on the nipple, we will have posterior shadowing and nothing will be seen. So this placing the probe straight is a wrong technique. While if we do peripheral compression, two-hand held compression or rolled nipple technique, we can easily see the retroareolar region, and we can diagnose even the smallest intraductal papillomas. This is a 37-year-old female complaining of bloody nipple discharge. Cytology revealed no malignant cells. There was a global asymmetry of the left breast, and when we performed complementary ultrasound examination, we can see that there are multiple intraductal lesions, some of which show a central vascular pedicle. You might say that this examination is enough, but for the surgeon, this is not enough. Yes, he knows that we have intraductal lesions, but he needs to know the distribution of these lesions in the breast. So in these cases, we might recommend for further contrast imaging. And as you see in contrast imaging, although it is not diagnostic of the intraductal location of these lesions, but it shows us the actual distribution of the papillomas within the breast. The patient underwent major duct excision, and these were intraductal papillomas with atypical ductal hyperplasia. This is another young female coming with left and bloody nipple discharge, and it is evident that there was an intraductal soft tissue lesion that was vascular. This was the MRI of the same patient, and actually it added nothing because it showed us the same distribution and the same lesion which we already saw on the 2D ultrasound. This was a patient, she underwent a left major duct excision for duct ectasia, and now she came back with a complaint of bleeding per left nipple. This was her contrast mammogram, and it revealed a malignant enhancing mass lesion at the operative bed, and this is how it looked on the ultrasound examination. This is another case. She's a 45-year-old presenting with a palpable left breast mass lesion. This was the ultrasound which revealed a hypoechoic mass lesion. She was managed with a conservative surgery, and this mass lesion was removed. On one of her follow-ups, she came again. It was an invasive duct carcinoma. On one of her follow-ups, she came complaining of bleeding per left nipple. This was the tomosynthesis and the mammogram of the patient, and both were not diagnostic. While on the ultrasound examination, we saw an irregular hypoechoic mass, and we suspected the presence of recurrence at the operative bed. And actually, this was her MRI, which showed the same findings, and this was operative bed recurrence. Now we come for the last station, and it will be discussed in a separate lecture than my next lecture. So we will bypass it, but I want you to know one simple information is that in mastitis, again, ultrasound takes the upper hand in diagnosing mastitis. So when we want to have a broad overview of what we have been saying, and that is we can classify patients into asymptomatic and symptomatic patients. For the asymptomatics, regular screening mammography is recommended starting the age of 40. If we have 3D digital tomosynthesis or automated breast ultrasound, they both increase the detection and decrease the recall rates of the patient. Ultrasound enablers are of specific use in the dense breast and in lesion characterization, and contrast mammography has the potential to be used in the future of high-risk individuals. For symptomatic patients, we either start with an ultrasound or a mammogram according to the age, and they are usually enough. Ultrasound takes the upper hand in intraductal lesions and in mastitis, while contrast mammography and MRI are useful to identify the multiplicity, multifocality, the extent, and the presence of occult lesions. And to end my lecture, definitely in the last decade, we have witnessed an intense increase in the volume of breast imaging techniques with the development of new technologies and the upgraded application of already existing ones. These new breast imaging technologies are meant to enhance the evaluation of patients with breast problems by ruling out the presence of breast cancer and in the same time addressing the patient's symptoms. Yet the challenge will always remain, how can we achieve this goal by using the right modality in the right time and for the right person? And thank you.